Bismillahirrahmanirrahim. Quote of the day is difficult roads lead to beautiful destinations. My name is Dr. Aamna Khalid. I will be presenting the topic of case control studies under the kind supervision of Professor Dr. Zaida Afzal, who is Dean Institute of Public Health, Lahore. Learning objectives for the presentation will be we will define case control study design, understand the indications and rationale, uh, explain selection of cases and controls, then describe the exposure assessment methods, calculate and interpret odds ratio, understand matching and its implications, identify what biases and confounding are present, differentiate case control study from other study designs, and the strengths, limitations, and applications of this design. So this is observational and analytical epidemiological study design, where participants are selected based on the disease status. The previous exposure history is compared between groups, and this study design is useful for identifying the possible risk factors, and this is frequently used in the outbreak investigations and for rare diseases. And the question we start with is, okay, did exposure occur more frequently among cases or than controls? So this is the historical background. That the landmark study was the study of smoking and lung cancers. This was the earliest modern epidemiological applications of the case control method, establishing the causal association between smoking and lung cancer. So, formally defining case control study, this is an analytical observational study in which individuals with disease or outcome, which are labeled as cases, are compared with individuals without disease, which are controls. Past exposure status is assessed, and association between exposure and disease is estimated. So, the direction of inquiry will be from the disease to the past exposure. So this is the basic study design where the disease status is present in the cases and absent in the controls, and exposure history is assessed in both of the groups retrospectively. These are the main characteristics of case control study design, that this is an observational study. No intervention is done. This is analytical design, means it attests the hypothesis. This is usually retrospective in direction, begins with the outcome or the disease status, and compares exposure frequency between both the groups. It cannot directly calculate incidence or risk. The main measure of association in this study design is odds ratio. So when to use case control study design when the disease is rare, like some uncommon cancer. The disease has long latency period. Outbreak investigation is needed urgently. Multiple exposures need to be studied simultaneously. When quick and inexpensive study is required, and when the ethical concerns prevent experimentation. So these are the common applications. These studies are done in the cancer epidemiology, in the outbreak investigation of infectious diseases, occupational epidemiology, environmental exposures, adverse effects, maternal and child health research, genetic and molecular epidemiology. So types of the case control studies um, can be based on the basis of the timing. It can be retrospective, which is the most common method. Both disease and exposure are already present in the two groups. Then the second one is nested case control study, which is conducted within an existing cohort study. We will go through the detail in next slide. By the source of control, we can label case control studies as the hospital-based, community-based, neighborhood-based, and the friend or relative-based controls. So first step in this study design is the selection of cases where they are clearly diagnosed using the standard criteria of diagnosis. This group is representative of all the cases in the population, and these are the newly diagnosed, means incident cases, which are preferred instead of prevalent cases. And the sources of cases are can be hospitals, disease registries, surveillance systems, and community surveys. So the incident versus prevalent cases. Incident cases are preferred in this study design, and these are the newly diagnosed at the start of the study. and they reduce the survival or Neyman bias. This bias will be discussed in next slide. Exposure is more accurately recalled, and better temporal relationship can be established. In prevalent cases, existing cases which are present at the start of the study are the prevalent cases. They are easier to collect and they are in larger numbers, but they may introduce the survival bias, and recall of distant exposure is unreliable as well. Then the second step is a selection of controls. They come from the same source of population as cases. They represent the exposure distribution in the general population, and they must be free of the disease under study and comparable to cases in other characteristics, means the characteristics which are not under study. So the golden principle is if a control developed the disease, they would qualify basically as a case. So how many number of controls are required? Usually 1:1 ratio means one control per one case is selected, but we may increase to 1:2 or 3 or 4 for greater statistical power. Increasing the controls will improve the power, especially when cases are few. Benefit will reduce substantially beyond 4 controls per cases. So this should be the maximum ratio, not beyond that. Then we have to do the exposure assessment, and there can be different methods of exposure assessment in both the groups. We can do the interview, which can be structured or semi-structured. There can be self-administered questionnaires, or the medical or clinical records can be reviewed. Laboratory tests and biochemical markers can be done. Occupational and industrial records can be found. Environmental monitoring data can be obtained. These are the sources of data. In case of interview, the advantage of interview is that this can be detailed and flexible, but the problem is the recall bias, which can occur in interview. The second source is medical records. The advantage of this is this can be objective and historical, but the disadvantage is the data may be incomplete for our requirement. Biomarkers are accurate and measurable, but the problem is that they are expensive and invasive. Registries provide a large data sets, but in registries there can also be incomplete data or the missing variables. So then we have to match the two groups even before the assessment of the exposure impact. And the technique, this is a technique to ensure similarity between cases and controls regarding the confounders. I will tell about the confounders as well in next slide. The purpose is to reduce the confounding and improve comparability. The matched variables, which are usually matched, are age, gender, socioeconomic status. And the matched analysis requires the special statistical methods like McNemar's test and the conditional logistic regression. And there can be different types of matching, like individual matching and the frequency matching. In individual matching, each case is matched with one or more of the specific controls, and there is precise control of the confounders in this case. For example, a matching on exact age and sex. These are, as discussed before, analyzed by the different methods. Frequency matching is the overall distribution of confounder matched. This is more flexible than the individual matching. This can also be labeled as group matching. For example, the same age distribution is found in the both groups. So they are analyzed by the standard methods. So advantages of matching are they control the confounding effectively, they improve the statistical efficiency, they increase the comparability of the groups, and they're especially useful for the strong confounders like age. But the disadvantages are that they can be time consuming to find the matched controls, and this method can be difficult when multiple variables are matched, and overmatching may also occur, which can also produce bias, and cannot we cannot study the matched variables as exposure later. So then we see the association. To see the association of the exposure and disease, we first have to make this 2 into 2 table where the cases and controls are taken on the vertical axis and exposure, or if not exposed, this factor is taken on the horizontal axis, and odds ratio is calculated by as a cross product, A into D over B divided by B into C. So this is the odds ratio. This is the main measure of association in case control studies, which estimates the strength of association between exposure and disease. And this is basically the approximation of relative risk when disease is rare, because relative risk cannot be directly measured in the case control studies. This is measured in the cohort studies. So the interpretation of odds ratio is that if it becomes equal to 1, this means there is no association, means exposure is not related to the disease. If the value is more than 1, then it means it has a positive association, means the exposure is actually a risk factor for the disease under study. And if the value is less than 1, then the association is negative, means the exposure is basically protective for the disease under study. So this is the example where um, 80 smokers had lung cancer and 20 non-smokers had lung cancer, and 40 smokers did not had lung cancer, and 60 non-smokers did not had the cancer. So when we calculated the odds ratio, it came out to be 6. So smokers had 6 times higher odds of developing the lung cancer compared to non-smokers. This is the interpretation. So confounding, we talked about it that matching will reduce confounding. So confounding is a third uh, variable that is associated with both exposure and the disease. This distorts the true association between exposure and outcome. For example, age can confound the relationship between coffee and heart disease, or smoking can confound the alcohol and lung cancer relationship, because these factors are associated between with both the exposure and disease. So how to control the confounding factors? They can be controlled in the design phase and during the analysis phase as well. During the design phase, we can do restriction, means limit the study to a specific group. Then matching, as we talked about it, between cases and controls. Randomization, but this is not possible in observational studies. If we specifically talk about a case control study, then matching is the preferred method. Then during analysis phase, we can apply different methods like multivariate analysis, logistic regression, and the stratified analysis uh, to reduce confounding. So these are the different kinds of bias which can be present in the case control studies. Like bias basically is a systematic error which is causing the incorrect result. So selection bias can be there, means cases or controls are selected differently. Recall bias, cases remember exposures better than the controls. Interviewer bias, where the differential probing of the cases versus controls occur by the observer or the interviewer. Information bias, there can be inaccurate exposure measurement. Parkinsonian bias, where hospital-based selection distorts the results. Means if we take data from hospital, the disease will be more dominant in those people. Then the survival or Neiman bias, where only survivors are included in the cases. Misclassification bias means incorrect exposure or disease classification. So, if we talk more about the selection bias, the cases and controls are selected through different processes. The controls are not representative of the source population, and the different participation rates are present between the groups, and the hospital controls differ from the community. And how to prevent them? We can use a same sampling frame for the cases and controls, maximize the response rates equally, use the multiple control sources, and avoid hospital only controls for community diseases. So for recall bias, cases may recall exposures more thoroughly than the controls. For example, mother of the malformed baby recalls the drug use more carefully. This leads to overestimation of the odds ratio. So prevention of recall bias can be done by using the objective records and biomarkers. Interviewer bias means when the interviewer probes cases more than the controls. This occurs when interviewer already knows the disease status, and this can be prevented by blinding the interviewers to the disease status. And standardized questionnaires can be used, and training and retraining can be done. Parkinsonian bias is when a hospital-based study phenomena and the combination of exposure plus disease. will increase the hospitalization probability. This creates the spurious association, means the wrong association, and we can say even if none exist, and prevention can be done by using the population-based controls. Then the survival bias, or the Neiman bias, when only survivors are included as cases, the severe or fatal cases are missed completely. Prevalent cases are more affected than the incident cases. This can be prevented by using the incident cases and a fast enrollment. So these are the strategies to reduce bias. We have already discussed them one by one. So the statistical analysis methods used are the odds ratio, which was already discussed previously. This is the main measure of association. Then we have to take the 95% confidence interval, which is the precision of estimate. Chi-square test has to be used for the as a test of statistical significance between the categorical variables. And when chi-square is not applicable, means when the cell counts are less, then instead of chi-square, we use the Fisher's exact test. And the logistic regression is used to adjust for the confoundings and the multiple variables. And the McNemar's test is used for the math studies. So if we talk about the confidence interval, in this case, if it excludes the value of 1, for example, it ranges from 2.3 to 5.6, then we say that the association is statistically significant. But if it includes the value of 1, for example, if we start up from 0.8 till 3.2, then 1 is the part of it. So now we say that the results may not be statistically significant. A narrow confidence interval will provide more precise estimate, but we will have to take the larger sample size. Then we come to the nested case control study. This is the case control study which is conducted within an existing cohort study, where cases are basically the cohort members who develop the disease with time, and controls are randomly sampled from the risk set at time of each case. Advantages of this adopting this method is there will be less recall bias when exposure is reported before the disease, and it will be a cost-effective method, and it uses the stored biospecimens. So this preserves benefits of both the cohort and case control designs. Then a cohort study. This is a variant of the case control design nested within a cohort, where controls are selected from the whole cohort at baseline. And the same comparison group is used for the multiple outcomes, and this allows calculation of the incidence rates as well, unlike the standard case control study where we cannot basically directly calculate the incidence rates. This table differentiates the case control study from the cohort study. In case control study, this design starts with the disease, but in cohort we start with the exposure. The direction of case control is backward, retrospective, and in cohort, forward. But we will see mainly forward prospective, but we will go through the detail as well in the next class as well, where we will see different study designs of cohort. Case control is best for the rare diseases, and cohort is best for rare exposure. The cost is less in case control and more in cohort. Time required is less in case control, and more time is required in cohort. Main measure of association is odds ratio in case control and relative risk in cohort. And incidence is not directly calculable in case control, but it can be calculated in the cohort study. So the advantages of a case control study is that it is a fast and relatively inexpensive method. This is ideal for rare diseases. Smaller sample size is required. Multiple exposures can be studied simultaneously, and this is useful for the diseases with long latency period. And ethically, there is no intervention required. Then the disadvantages are that we cannot calculate the incidence directly. Temporal relationship may be unclear. High susceptibility to bias is present. We talked about different biases. Recall problems are common. This is basically bias. Not ideal for rare exposures, and control selection can be difficult. Causality in case control studies can support causal inference when the Bradford Hill criteria can be applied, and some of the points are from this criteria are present, like there is strong association which exists, means a high odds ratio, consistent findings are there, dose response relationship is present, temporality is present, means exposure is present before the disease, and biological plausibility exists. Then we can infer that a case control study can be causal. The ethical considerations in case control studies are that informed consent must be obtained from all the participants. Privacy and confidentiality have to be maintained for the health data. Sensitive exposure questions require careful and respectful handling. Data security protocols must be implemented. Ethical committee or the IRB approval is required before study start, and this is in fact a thing for all of the study designs. Basically, vulnerable populations need additional protections. So if we have to critically appraise the case control studies, we will follow the stroke guidelines. Um, I will talk about it in the next slide as well. But major questions we have to keep in mind while doing this study, or while critically appraising some article based on this study, are that were cases properly defined using clear and standard criteria? Were controls selected from the same source of population? Was exposure measured accurately and consistently? Were biases identified and minimized? Were confounders adjusted for in the analysis? Is the odds ratio clinically and statistically meaningful? And were the stroke guidelines followed for reporting? The stroke guidelines are basically stroke stands for strengthening the reporting of observational studies in epidemiology. This reporting guideline provides a checklist for transparent and complete reporting of each and everything. For example, it covers the study design, participants, variables, bias control, statistical methods, results, discussion, and this is available on the internet, and this is widely required for the peer-reviewed journals for submission. So if we talk about some example uh, of smoking and lung cancer, the cases are lung cancer patients admitted to the hospital. The controls are non-cancer patients from the same hospital, and the exposure is smoking history, its type, duration, quantity, and then we see the results by calculating the odds ratio, which comes out to be around 6 to 10. So this is how we move from the selection of cases and controls, assessing the exposure and finding the results in form of odds ratio. So if case control study is used for outbreak investigation, there is a scenario that food poisoning outbreak occurs at a community event. Cases are the individuals presenting with acute diarrheal illness. Controls if the event attendees without the gastrointestinal symptoms. So we will see the exposure that the foods consumed at the event, like meat, salads, desserts, beverages, whatever is used there. And then we do the analysis. Odds ratio is calculated for each food item separately. The result is that the food item with highest odds ratio identified is the as a, is basically a vehicle for of transmission. So then the relevant action will be taken. Rapid public health intervention is implemented. So these can be the modern applications of case control study. This can be used in a genetic epidemiology, identifying the susceptible gene variants, molecular epidemiology, where the biomarkers are used as exposure measures, uh, pharmacovigilance. Pharmacovigilance means the drug adverse event are monitored, environmental toxicology, vaccine safety monitoring, COVID-19 or other emerging infectious diseases. Research can be done on this basis. So this was all about the case control studies. Now we come to the MCQs. Question number 1: a researcher selects patients with lung cancer and compares their past smoking history with the healthy individuals. What study design is this? Option A, cohort study. B, cross-sectional study. C, randomized trial. D, case control. And E, ecological study.
D.
Yes, D is the right answer. Question number
D.
2: during a food poisoning outbreak, Investigators compare food intake history of affected and unaffected individuals. What is the main measure of association? Option A, relative risk; B, incidence rate; C, odds ratio; D, prevalence ratio; and E, hazard ratio.
E.
C, odds ratio. Question number 3. Study on a rare cancer selects 100 cases and 100 controls. Why is this design preferred? Option A, it calculates the incidence. Option B, it is best for rare exposure. C, it is efficient for rare disease. D, it eliminates bias. And E, it measures prevalence.
C.
Yes, C is the right answer. Question number 4. Which statement best describes direction of a case control study? Option A, from exposure to disease. B, from present to future. C, from disease to past exposure. D, from population to sample. And E, from exposure to outcome.
C.
Yes, C is the right answer. Question number 5. Which situation is least suitable for a case control study? Option A, rare disease. B, long latency disease. C, rare exposure. D, outbreak investigation. And E, cancer study.
C.
Yes,
A.
C, rare exposure. This is a for rare exposure, we will do cohort study. Question number 6. A third variable associated with both exposure and outcome distorts the relationship. This is option A, bias; B, confounding; C, interaction; D, effect modification; and E, random error.
B.
Confounding.
B.
B. Yes, B is the right answer, confounding. Question number 7. A study is conducted within an existing cohort where cases are identified and compared to the selected controls. This is option A, cross-sectional; B, nested case control; C, ecological; D, randomized; and E, case series.
B.
Yes, yes, B
B.
is the right answer, nested. Question number 8. Which bias occurs when interviewer probes cases more deeply than controls? Option A, recall bias; B, selection; C, observer; D, confounding; and E, Wilkinsonian bias.
C.
Yes, C is the right answer. Question number 9. An odds ratio of 0.3 is reported between vaccination and disease. Interpretation is option A, no effect; B, harmful effect; C, protective effect; D, bias; and E, confounding.
B.
A.
Sorry, C.
A.
C is the right
A.
answer, protective effect. A will be when value is equal to 1. Question number 10. Which of the following cannot be directly calculated in case control studies? Option A, odds ratio; B, relative risk; C, odds exposure odds; D, association strength; and E, confidence interval.
B.
Yes, B is the right answer. This is the answer key. This is the YouTube channel of IPH where this presentation will be uploaded. And thank you.
Thank you very much, Dr. Amna. This is a very good presentation.